I want to welcome everybody to the 21st Century Cures Act webinar sponsored by Friday Eldredge Clark. Because of their sponsorship, we are able to offer this event for free to the AHA members. My name is Lindsay Dumas. I'm the Vice President of Education here at the Arkansas Hospital Association. So with that, I'm going to turn it over to Lynda Johnson and Amie Alexander with Friday Eldredge Clark. Lynda, I believe you're going to start first.
Yes, thank you, Lindsay. Well, good morning, everyone. It's good to have everyone with us here this morning. We're going to talk about the 21st Century Cures Act. And see, I almost said CARES Act. So if you thought you were going to hear about the CARES Act, unfortunately, you're going to hear about the Cures Act. The Cures Act was actually signed into law by President Obama back in 2016, and then it was bolstered by an executive order that was signed by President Trump. And both the act and the executive order contained directives that are related to interoperability and data exchange. Now, I will tell you, this act and this executive order are very technical. They relate to a lot of IT and technical issues that are way over my head. We're not going to go into those details today because they do not require compliance on the provider side. We're going to focus on the compliance issues that are facing providers in the Cures Act. But we have information on our slides that refer to these deadlines and these compliance issues for the software providers so that you will be aware of them. It's been our experience in the past that the software providers tend to push off these deadlines that they have until the very last minute, and then they try to say that it's not their problem, that it's the provider's problem. And so we feel like it's important for you to know what their requirements are and what their deadlines are. But a lot of this is very, very technical, and we will not be going into detail about those requirements today. There are, though, two final rules that are in place as a result of the Cures Act and the executive order that do pose compliance concerns for healthcare providers, and those are what we're going to focus on today. These final rules advance interoperability. They support the access, exchange, and use of what is called electronic health information, or EHI, under the Cures Act. Now, you'll note that's a different term than we're used to using. We're used to using the term PHI, Protected Health Information. So that's a little bit of a change in terminology, but there is some overlap between these requirements and the HIPAA requirements, and Amie will be talking more about that later on. These rules also pose compliance concerns with respect to something called information blocking. And we'll be talking a lot more about that term as we go through the material this morning. And then finally, these rules actually modify the hospital conditions of participation. As these rules require hospitals to issue admission, discharge, and transfer event notifications that are effective in the spring of 2021, which obviously is not that far away. So we'll be discussing the Cures Act definition of information blocking. We'll discuss the 8 exceptions that are carved out in this final rule. We'll discuss the compliance concerns that are posed with the information blocking regulations. We'll talk about what you've got to accomplish by this November 2nd, yes, November 2nd, 2020 compliance deadline, which is less than a month away. And we'll identify what the requirements are and what steps you should take to avoid being subject to CMS's public listing of providers that are engaged in information blocking. In other words, you don't want to end up on CMS's public wall of shame. So the 21st Century Cures Act was actually signed into law on December 13th, 2016. It had strong bipartisan support. It authorized a lot of money, $6.3 billion in funding, but most of that was for the National Institutes of Health. There was some money provided for small business health reimbursement, a lot for research and drug development. There was a fast track drug approval process that was provided for by the Cures Act. There was a lot of money put toward behavioral health, some toward healthcare access and quality improvement. And then the last prong, which is what we're going to focus on today, was dealing with electronic health records and information blocking. So just some general provisions of the Cures Act. There were funds allocated for opioid misuse prevention efforts and biomedical research. There was this accelerated drug and medical device approval process and a bolster of mental health treatment reform. The focus on health data was primarily to encourage patients' electronic access to their health information, to promote interoperability, and then to inhibit what is called information blocking. And information blocking is a new term, but it is the focus of a lot of what we're going to be talking about today, and a lot of what your compliance efforts prior to November 2nd are focused on. So while the act was signed in 2016 by President Obama, President Trump on October 12th of 2017 signed an executive order that promoted healthcare choice and competition across the United States. And this executive order aimed to improve access to and quality of information that Americans need to make informed healthcare decisions, including data about prices and outcomes, while supposedly minimizing reporting burdens on affected plans, providers, or payers. So with that overall picture in mind, now I'm going to turn it over to Amie as we shift the screen here a little bit. And Amie is going to talk about the CMS final rule, which is one of the two final rules that we're going to talk about today.
Hello, I am Amie Alexander, and as Lynda kind of set the context, we have the Cures Act and the executive order that really started the rules and compliance issues that we're focusing on today. But we have two final rules that we'll deal with, and the first is the CMS final rule. And that final rule is called the Interoperability and Patient Access Final Rule. It was finalized in May of this year. And what this rule finalized, it finalized 4 new policies for payers, for CMS payers, and 3 new policies for providers. And so the CMS payer policies that are new are only applicable to Medicare Advantage plans, Medicaid, CHIP, for qualified health plans that are in the federally facilitated exchange. So these won't be applicable to commercial plans yet, but you might hear things about your CMS payers having to comply with these new requirements, and it's probably a good indication of what will be required across the board in the future. So there are 4 new rules that CMS payers have to abide by, and we'll go through those just so you're aware of them. And really what we'll focus on here, though, are the 3 new policies that will apply to providers. And I do want to note that if you do have sponsor your own health plan that includes Medicare Advantage plans, then the payer policies might also apply to you. So before we get started here, I want to kind of define this new information. As Lynda talked about, we have several new terminology here. So we have information blocking, which we'll get into further in the presentation. We have electronic health information, and we also have something called API. That's application programming interfaces. But throughout the presentation, I'll just refer to it as API. An API is a set of commands, functions, protocols that are published by a software developer. So think of, when we're talking about APIs, think of an app on your smartphone. This enables the other developers to create programs, which are these apps that interact with the software. So before a third-party app company can develop an app to go on your smartphone, there has to be this interface called an API that has the information to do so. So this API allows 2 softwares to communicate without knowing its internal workings in a way that maintains consumer data privacy. So as we mentioned, this part is much more applicable to health IT developers, but it is terminology that's used throughout the rule and through your compliance concerns, so we wanted to touch on it. So really what the interoperability and patient access final rule focused on, CMS said that the touch points of this rule were first enabling patients to access their electronic health records without any special effort through APIs. So in the long run, CMS is intending that this rule will help patients be able to access their health information through an app on their smartphone of their choosing. CMS also says this rule will help providers have access to information on patients regardless of whether or where they previously received care. And it prevents providers from what they say is inappropriately restricting the flow of information between providers and payers. And they say this will reduce the burden overall on providers because more information will be available on these patients. CMS also says that this rule will ensure that payers can make enrollee electronic health information available through the API. So patients should be able to access their health records through an app on their smartphone and access their payment information. And then finally, CMS hopes that this rule will make it easier for both patients and providers to identify other providers in a plan's network for patients. So those are sort of the context and touch points that CMS hopes this rule will help achieve. CMS as a core policy principle in this final rule is that kind of the motivation behind it is that every American should be able, without special effort or technical skills, to see, obtain, and use all electronically available information that's relevant to their health care, choice of plans, providers, and special treatment options. And I mentioned this, but it is important to note this includes both information about the individual, which brings privacy concerns and compliance issues, which we'll focus on, and it includes information of general interest that should be widely available. So maybe providers who are in a provider's network, in a plan's network, coverage policies, drug formularies, that type of information. In developing this final rule, CMS put out some requests for information from providers and software companies and developers about what's really hindering interoperability or what's hindering the free information sharing. And what the feedback they got back was that they have issues with, there's a lack of a unique patient identifier, there's lack of standardization across the industry. They did identify information blocking as a barrier, which is why we have a whole other rule to cover information blocking now. They cited lack of adoption through certified health information technology among post-acute providers, and privacy concerns, which is why we have a lot of overlap with HIPAA. So CMS took this feedback and implemented it into its final rule on interoperability. As Lynda mentioned, a lot of this is very in the weeds and has to do mostly with developers and IT and software companies, but we've been talking a lot about interoperability. This is the definition from the Cures Act. It's overly complicated. Really what interoperability is, it's just in the context and with respect to health information technology, interoperability ensures that we can securely exchange electronic information without some sort of special effort or skills. So a simple way to exchange electronic information that allows for complete access, exchange, and use of this information in a secure way. So really, it's just being able to exchange information in a secure way that doesn't bring a lot of overly complicated barriers. Now, this table is a summary of what changes were issued by the CMS final rule. As I mentioned earlier, it applies to both providers and CMS payers. For CMS payers, which again are Medicaid, Medicare, CHIP, Medicare Advantage plans, or qualified health plans through the exchange, there were 4 rules, but I have 2 listed here that are actual policies that will go into effect in July. They were originally to go into effect in January, but some of our compliance deadlines were pushed off due to COVID. And for providers, we have 3 policies that really affect our providers. The admission, discharge, and transfer event notifications that Lynda mentioned and we'll discuss in a little more detail. We'll have to start complying with those in May. And the other 2 instances where you could be published on CMS's kind of wall of shame of providers who engage in information blocking, those are effective this fall. And so we'll talk about the steps you need to comply with those so you can avoid being listed on that list. So I want to walk through these policies sort of one by one. As we mentioned, the first 4 really apply to CMS payers, but we still need to be aware of them. The first is called Patient Access API, and remember API is that the third-party application. So CMS payers are required to implement and maintain a secure standards-based API by January. That was originally January. It was pushed off until July. And this API should allow patients to easily access their claims and information. So that will be something that you might hear about from CMS payers implementing in the spring. But that's something that'll be coming that will have compliance concerns for providers later on, but not right now. The second is called a Provider Directory API. So CMS payers will be required to make provider directory information publicly available in this app system. And this information will allow third-party app developers to access this information so that app developers can create services to help patients find providers and treatment. And it will likely help clinicians help patients find care coordination as well. And so that's something that'll be coming and starting next year. So you'll be hearing more about that in July. It was originally scheduled for January, but now it's been pushed off until July. The third policy is a little further down the line. Again, this is only CMS payers, but CMS payers will be required to exchange certain patient clinical information at the patient's request, which will allow this patient to take their information with them as they move between different payers. and these payers are required to implement a process for this exchange between payers. Now that doesn't take effect until 2022. And then finally, this is more applicable to states and not necessarily to payers, but this is targeted towards dually eligible beneficiaries, so patients who are eligible for both Medicare and Medicaid. Previously, states were just required to update this information monthly about which beneficiaries were eligible for both Medicare and Medicaid, but starting next year, starting in 2022, states will have to update this information daily. And so CMS says that will help decrease confusion around dual beneficiaries. But that's something that is a little further off, but will come into effect in 2022. And then finally, we have the policies that are really applicable to providers. So the first is public reporting and information blocking. Beginning in late 2020, there is not an exact date that's published on this, so this fall, so it's important to talk about this as soon as possible. CMS will begin publicly reporting clinicians and hospitals that may be information blocking. And this is based on how they attested to program interoperability program requirements. I have a little more information on this in 2 more slides, so I'm not skipping it. And then also beginning in late 2020, CMS will begin publicly reporting providers that either do not list or do not update their digital contact information in the National Plan and Provider Enumeration System. So these are really the 2 most important things about the CMS final rule for providers. One is geared toward the prevention of information blocking, and it applies to providers that attest to information blocking statements as part of the program promoting interoperability program requirements. There are 3 questions that are related to this in those attestations. And so if you attest no to the statements about preventing information blocking, then you are at risk of being publicly listed. And so to avoid that, continue to attest in these systems that you do not engage in information blocking. And then the digital contact information issue, you are encouraged to include that digital contact information previously, but now you'll start seeing some harm if you don't include that or update that in that system. And Lynda had a little more to add about this requirement.
And on the digital contact information for MIPS purposes, if you're not able to attest that you're not engaging in information blocking, Medicare is going to be able to decrease your Medicare reimbursement, which that is a really, really stiff penalty. So it's absolutely vitally important that you be able to attest that you're not engaging in information blocking. Now, we're going to be talking a lot more about what constitutes information blocking, so don't think that we're going to leave you hanging there about what is and what is not information blocking. So, but I did want to point that out, that it's vitally important that you be able to attest that you're not engaging in information blocking. Okay, so I'm going to turn it back over to Amie to talk about that last last new policy.
I have one more policy to check out. This is going to be down the road a little, starting in May 2021. But as Lynda mentioned, the hospital conditions of participation have been changed. This has been added in to require hospitals and providers to submit electronic notifications through one of those API systems when that's available from the vendor. These electronic patient event notifications should notify people in the provider's network, people in the patient's network, of a patient's admission, a patient's discharge, a patient's transfer to another healthcare facility, or transfer to another community provider or practitioner. CMS has said that this requirement will eventually create a better continuity of care for patients if they have that electronic notification in their records. And that's something that the patient can choose to let that go out to their primary care physician or providers of their choosing. But that isn't coming until May 2021, and it requires the vendors to make some changes before you all can implement anything to do with this. But it's just a summary of what's on the horizon. So I know that was a crash course in the CMS final rule, but really just to reiterate a summary of what's important for providers here. Make sure that you review statements in your MIPS reporting if you have clinics to make sure that you do not engage in information blocking. As Lynda mentioned, we'll focus much more on what is and is not information blocking later, but this has not been a big deal yet when you've been filling out these attestations. So now is a good time when you're reviewing your policies for information blocking to go back and make sure that you have not checked those boxes. And make sure that you update your, or if you've not provided it previously, if you can, make sure to include that digital contact information in PPES system, and that will help avoid you being listed on the CMS's website as participating in information blocking. And then finally, this is coming next year, but be on the lookout for those patient event notification abilities and prepare to make admissions, transfer, and discharge notifications in May 2021. So I'm going to turn it back over to Lynda to focus on our second final rule, which is from the ONC.
And before I start talking about the ONC final rule, those notifications that you're going to have to start making in May of next year, we're totally dependent upon our software provider, to be able to do that. So even though May 2021 sounds like it's a long way off, I know these software providers, they're notorious for, oh, we'll take care of it. And before you know it, we're in April of 2021 and they haven't touched it. So it's very important that you start nagging on them now, because we know that they'll wait till the last minute. So now we're going to shift gears. Oops, sorry, went a little too far. We're going to shift gears and talk about the second final rule. Amie talked about the CMS final rule. Now I'm going to talk about the ONC final rule. Now, first of all, let's talk about what ONC stands for. It stands for the Office of the National Coordinator for Health Information Technology. Ooh, it's a mouthful. And I've got to admit, when Amie and I first started looking at this information, my question to Amie was, well, this rule doesn't apply to hospitals, does it? Well, it does apply to hospitals. So it's a very, I will tell you, it's a very complicated rule. This is the rule that defines the 8 exceptions to information blocking that are set forth in the Cures Act. Amie's going to talk about those exceptions. Those are really, really important. Amie's going to be talking about those. This final rule also provides updates for those standards that you had to meet for your EMR certification. So some of those EMR certification standards are going to change. Now, we're not going to get into a lot of detail on that because, again, that's one of those techie things, but there are updates there. But again, these rules and these exceptions do apply to providers. So this is a summary of the changes that are in the ONC final rule. The information blocking, which is the biggie, that has the compliance date of November 2nd, which is less than a month away. That's the biggie. And Amie's going to be talking about the exceptions, which are really the exceptions are what, as or more important than what the rule is. And then the second thing that the ONC final rule does is it updates the electronic health record certification criteria. And it does that by doing these 4 things that are listed here, by adopting these different standards. These all apply on the vendor side. These do not apply on the provider side. But I put those dates in there so that you would know that those are the deadlines that your vendors have to meet in order for your EHR to continue to be able to be certified. So, in a sense, they are important for you to know, because if your vendor doesn't meet their deadlines, then that means that you're not going to have an EHR that's going to be able to be certified. So from the big picture standpoint, the ONC final rule, as far as providers go, supposedly, this final rule makes patient data request easy and inexpensive. It allows patients to use their choice of apps. It helps you implement this whole process, and it improves patient safety. So, as I said, this ONC final rule is complicated, and the majority of it is targeted toward health IT developers. It establishes the conditions of certification requirements for the ONC Health IT certification program. And IT developers will use this program to develop applications for patients to access their EHR. And there's a long-term implementation of this final rule, and we've kind of set forth what this process is 2 slides over. Oops, there we go. So this is the long-term implementation plan, and you see it goes all the way out to 2023. So this time period does not affect providers. This is for the health IT developers, and we've included it just so that you see that the ONC is mapped out what they expect out of the health IT developers, for the next basically 4 years. So that's what's coming down. That's what's coming down the pike. So as far as what you need to know about the final ONC rule, you need to know about the information blocking rule. Something to keep in mind is the information blocking rule refers to an actor, and that's an unusual term, but so that you will know, providers, all of you, are considered an actor for information blocking purposes. Also considered as actors are IT vendors, health information networks, and health information exchanges. So you're not referred to as a provider in the information blocking rules. You're referred to as an actor. And there are those 8 exceptions to information blocking. And Amy's going to tell you all about those 8 exceptions, which are very important. And they're almost as important as what the rule is. The second important topic that you need to know about from this final rule is with regard to updating the 2015 edition of the certification of the electronic health record. And it requires a lot of things from the IT vendors to update your electronic health record. So unfortunately, we're going to be going through a lot of painful exercises, I feel like, in updating those electronic health records. It seems like just when we get used to the way that they work, then they start changing the rules on us. So it looks like we're going to be going through the changing of the rules again. And then finally, the third thing is the maintenance and conditions of certification. Your IT vendors, in order to maintain their certification, they have to update their requirements. And so in order for them to provide you with a product that is certified, they're going to have to update their product. And in order for them to update their product, then you have to update your EHR. So this whole process, you know, encompasses the whole world of health IT, which is health information technology, which is the use of computer hardware, software, or infrastructure to record, store, protect, and retrieve all of this information, whether it's clinical, administrative, or financial. And of course, it can include electronic health records, personal health records, electronic medical records, and then the e-prescribing records as well. There's our timeline again. So now we're to the point where we need to talk about what exactly is information blocking. Information blocking is a practice that's engaged in by any one of these actors. And the actors that are listed are a health IT developer of certified health IT, a health information network, a health information exchange, or, there you go, a healthcare provider. So that includes all of you. And it's this practice that is likely to interfere with the access, exchange, or use of electronic health information. That term EHI, again, different term than what we're used to dealing with. Used to dealing with PHI. This is EHI. And then there is except as required by law or specified by the Secretary of Health and Human Services as a reasonable and necessary activity. And then we do have those exceptions that Amie is going to talk about. But some examples of information blocking that is set forth in the Cures Act are practices that restrict authorized access, exchange, or use of the information for treatment and other permitted purposes. So you can see already, this is going to require some tweaking of your HIPAA policies, which we'll talk about more later. But this is going to require tweaking, because I really feel like, and Amie and I've had a pretty detailed discussion about this, if we set up a separate set of information blocking policies that was separate and apart from your HIPAA privacy policies, we feel like that's setting you up for failure, because then everyone's so used to looking at your HIPAA policies when it comes to access or use or disclosure that you would end up looking at your HIPAA policies and forget about the information blocking policies. So we feel like that in order to have a chance at complying, we feel like that we've got to incorporate the information blocking policies into your existing HIPAA policies. And then the second prong of this example of something that could constitute information blocking is if you implement health IT in a non-standard way that's likely to substantially increase the complexity or burden of accessing, exchanging, or using electronic health information. So those are a couple of examples. We have some others. So implementing health IT in ways that are likely to restrict the access, exchange, or use of electronic health information in exporting complete information sets or in transitioning between health IT systems. I think this goes toward being able to transfer them to these applications, or implementing health IT in a way that's likely to lead to fraud, waste, or abuse, or impede innovations and advancements in health information access, exchange, and use, including healthcare delivery enabled by health IT. Boy, that's a lot of words. So those are the some examples that are actually listed in the Cures Act. And some of the examples of information blocking that we think could occur actually in practice would be if you have the capability to provide same-day access to electronic health information in a form and in a format that's actually requested by a patient or by a patient's healthcare provider, but you don't provide it the same day, you take several days actually to respond, that could constitute information blocking. And if you charge unnecessary and unsubstantiated fees for the patient to access their electronic health information, that also could constitute information blocking. So now I'm going to turn it back over to Amie. We've talked already, we've mentioned these a lot, these 8 exceptions. These are very, very important, and a lot of these are going to have to be, or some of these are going to have to be incorporated into your HIPAA privacy policy. So I'm going to turn the screen back over to Amie, and she's going to talk to you about the exceptions.
So as Lynda covered the definition for information blocking, as you can see, it's very broad. And as you can see from the examples that are included actually in the Cures Act, those are pretty broad, and you could see how a lot of situations could fit into that. And so what was sort of scary when the Cures Act came out was we had this very broad definition of information blocking, which no one's supposed to do. But you can see that there are probably a lot of fears of, when someone can't access the information they need as soon as they want it, we're going to have the question of, well, is this information blocking? And so the really valuable part of the ONC final rule is because the ONC has defined what information blocking is not. And that is as important as the rule that you are not to engage in information blocking. Because with these exceptions, anytime that you have some sort of complaint about information blocking, if you have documented appropriately, you can say, no, this is not information blocking because this fits within this exception. And that's the documentation that you'll use to make sure that you don't have an issue with information blocking. And so there are 8 exceptions, as you've seen with the other information from these rules. Some of them are more applicable to health IT providers, software developers. We'll cover all 8 because they might be relevant for you. You may have an instance where you think that a software developer is engaging in information blocking with you. And so you need to be aware of all the exceptions, but I will highlight the ones that will be most important for providers. And so the Cures Act, as we've mentioned, defined information blocking and granted authority to the Secretary of Health and Human Services to identify what activities are reasonable and necessary such that they do not constitute information blocking. And those are the exceptions that we have in this final rule that we'll cover. Kind of broadly, you can separate these 8 exceptions into 2 different classes or categories. The first set involve not allowing patients to access their EHI. And so these are justifications for why you can deny access. The second involve procedures for allowing patients to access EHI. So we can kind of separate them into those 2 big categories. So this is publicized by ONC, just kind of an information graphic of what 8 exceptions there are. You can see that they've noted that The top 5, so the 5 in that top light blue, are exceptions that involve not fulfilling those requests or denying those requests. And those are based off of preventing harm, privacy, security, infeasibility, or health IT performance. And we'll talk about those in more detail. At the bottom, in the darker blue or teal, we have the exceptions that involve procedures for fulfilling those requests. We have first licensing, costs, and content and manner. So those are the 8 exceptions, kind of broadly. The first has to do with not fulfilling or denying these requests. This is the preventing harm exception. And so the rule says that it is not information blocking to engage in practices that are reasonable and necessary to prevent harm to a patient or person, provided these certain conditions are met. And as usual with legal issues, there are conditions that you have to satisfy for each exception, and that's something that you can look into later, or when you develop your policy, make sure that those exceptions have those conditions included. But we're going to have kind of an overview discussion of those exceptions today. Really, this exception focuses on a potential harm that could result from approving this request for information. So an example, if you have a request that if you approve this request and furnish this information, it could result in incorrect information being exchanged that might impact patient care. That's a situation that would fit within this preventing harm exception. So if you deny a request for information on the basis that it has a likelihood of patient harm, and this practice or this denying the request is reasonable and necessary to prevent that harm, then that is not information blocking. There are some key elements to the preventing harm exception. I've included those for purposes of the slides if you keep those for your records. And if you implement this into your policy, because it could be applicable to providers. But you must actually reasonably believe that the practice will reduce the harm. It can't be any broader than necessary. You have to discuss the type of risk, the type of harm you're trying to prevent, and how you'll implement that policy. And you must satisfy the condition concerning a patient right to request review if there is some sort of individualized determination risk of harm. So there's some documentation and analysis that goes along with this exception that you'll need to think about. The second, and what we believe will be the most common exception for you all, is the privacy exception. And that exception says that it is not information blocking if an actor does not fulfill a request for access, exchange, or use of EHI in order to protect an individual's privacy. Again, there are conditions that you need to meet, but essentially this is really the big overlap with HIPAA. So the objective of this is that if you are permitted to provide the access or information, then you should, but there are lots of laws, state or federal privacy laws like HIPAA, that might prevent you from furnishing that access. And if that's the case, then you certainly should not furnish the access. And so if you deny a request because of privacy concerns or because it would be a HIPAA issue, then that is not information blocking. There are sort of some sub-exceptions here that your situation might fall into. The first is called precondition not satisfied. So that's an instance where you are required by a state or a federal law to satisfy a precondition, such as patient authorization or patient consent to release that information. If you do not have that patient authorization or consent, so you do not have the precondition satisfied, and you deny that request, that is not information blocking. And that'll probably be the most common for you all. And so that's really where you want to look at revising your HIPAA policies to make sure that you have this covered. The second is really more applicable for a health IT developer. The third, respecting an individual's request not to share information, that's a sub-exception that you could use. And then the last is denial of an individual's request for EHI consistent with these laws, and these regulations that are cited are the exception for psychotherapy notes being shared and for information compiled in reasonable anticipation of or use in an administrative, civil, or criminal action or proceeding. And so you should already have practices for when those two things are implicated, but it's a good time to revise those to make sure that it reflects that if you deny a request on those grounds, that is not information blocking. The third is a security exception. This will probably also be applicable to providers. It is not information blocking for an actor to interfere with the exchange, access, or use of EHI to protect the security of that EHI. And so really the objective of this exception is it allows actors to have reasonable practices in place to safeguard against security risks. And so you'll have those already established in your HIPAA policies. And so this is another instance that does not constitute information blocking. The fourth that will probably also be applicable to you all, sort of a catch-all, it's the infeasibility exception. And it is not information blocking if an actor does not fulfill a request for access, exchange, or use of EHI due to the infeasibility of the request. And this exception really acknowledges that some circumstances are beyond your control and they pose a barrier to being able to access the information. So even though this is sort of a catch-all, you do have to be able to fit within one of these categories and document in your response why it's infeasible to fulfill this request. So one of these conditions is uncontrollable events. I think we can all say we are currently in the state of uncontrollable events, but those are things like natural or human-made disasters, public health emergencies, public safety incidents, telecommunication or internet service irregularity, regulatory authority. Those are all kinds of things that could be going on right now. So if you are not able to provide access to a request because of an uncontrollable event, that is okay. Make sure you document what that uncontrollable event is, why you can't provide that access, and you have to provide a written response to the requester within 10 business days. So don't get hung up there. Don't just say we can't fulfill this because we're in a public health emergency and forget about it, because that's not going to keep you from being engaged in information blocking. You have to make sure to fulfill that that response to the requester with the reason why you can't fulfill the request, and make sure you do it within those 10 business days. Another option is segmentation, which is where you can't separate the request of other EHR. And the third is more of a catch-all, infeasibility under the circumstances. And for that, you have to demonstrate through a contemporaneous written record or some other documentation that this is consistent with non-discriminatory consideration of factors that led to your determination this is infeasible. So if you do use that catch-all, make sure that you document why it's infeasible, and it's being applied universally across the board in a non-discriminatory manner. But I have a feeling in the coming months, years, I don't know, that uncontrollable events will be a commonly used exception. The next is the health IT performance exception. This is sort of geared toward health IT, but also just kind of a catch-all for when your software is down. It's not information blocking for you to take reasonable and necessary measures to make health IT temporarily unavailable. This may be when you're updating the system, maybe when you have an issue with the system and needs to get it worked on. That's not information blocking if you can't provide access to a request during that time. Really just recognizes the reality that technology is sometimes unavailable and doesn't always work for us, for example, due to required maintenance or upgrade. The sixth, I will tell you this is a complicated exception, so we're not going to completely go through it because it will be more relevant down the implementation timeline when our software developers have their implementation dates met and they have their systems up and running. But you'll need to know about this for the future. But in general, it's not information blocking for an actor to limit the content of your response in request to access, exchange, or the manner in which you fulfill it. And there are certain criteria for how you can limit the content and the manner of your response, but those will be much more relevant later on when the software developers have kind of come up to compliance with the system. The idea behind this exception is that there may be a limit to the type of data or way the data can be provided. It will be different for you for what you can satisfy when we are in 2022 as far as software compliance guidelines and when we are in 2025. You will be able to respond in much more meaningful ways in 2025 than in 2022. So this is an exception that will continue to evolve. Basically, it provides a framework to negotiate terms with software providers, and if you cannot do so, then there are a list of alternatives you can use. But this is not as important for you right now as it will be later on. Number 7, this is also much more relevant to software providers, but it might be relevant if you had some sort of business venture. It's not information blocking for an actor to license interoperability elements for EHI to be accessed, exchanged, or used. This allows actors to protect the value of their innovations and collect reasonable royalties in order to earn returns on their investment that they've made to develop, maintain, and update those innovations. So this is really an exception for fees for software vendors. Now, the last exception is for fees, and I wanted to touch on this specifically because it does have some overlap with HIPAA fees. And so the final exception that is really relevant for providers is it is not information blocking for an actor to charge fees that result, even fees that result in a reasonable profit margin for accessing, exchanging, or using EHI. This really enables actors to charge fees related to the development of technologies and provision of services that enhance interoperability, but does not allow actors to protect rent-seeking, opportunistic fees, or exclusionary practices. These fees must be based on objective and verifiable criteria that are uniformly applied, that are not discriminatory. They must be reasonably related to the actor's cost of providing the information, and they must not be based on whether the requester or the other person is a competitor. But I will note that this is, well, I'm going to focus on this, but this exception does not apply to a fee that is based on any part on the electronic access by an individual, their personal representative, or other person or entity designated by the individual to access the EHI. And so the fees exception is relevant to providers, but I don't want you to get that confused with our issues with right of access under HIPAA. So that's what I will focus on right now. We've had a lot of questions about this lately, especially with, the further use of EHI and these rules coming out. So the fees exception for information blocking does not mean that we do not have to satisfy the right of access rules under HIPAA anymore. So sort of a refresher on those. Covered entities may require the request to be in writing, but they cannot require any unreasonable measures, such as if the individual requests that their records be emailed to their email address. You cannot require them to come in and sign the form. So you can require that request to be in writing, but can't require any unreasonable hoops for them to jump through. If possible and readily producible, we must respond to those requests in the form and format requested. And if it's not available in the form requested, then a printout is acceptable. Typically, in the past, I should say, it's still in effect that the limit for responding to those requests is 30 days. However, the information blocking rules make it all the more problematic to wait longer than necessary. So if you can provide access to that information immediately, do it immediately. If you can't reasonably provide the information for 3 days, do it in 3 days. Do it in the time it actually would take you, because any delay or any longer than necessary could bring rise to allegations of information blocking, in addition to a right of access problem. And you can require fees for this. So you may impose a reasonable cost-based fee if the individual requests a copy of the EHI, or PHI in this instance. But that cost may only include labor for copying the requested information, whether that's paper or electronic. You'd include the labor cost, what it costs you to pay that employee. You can include supplies for creating a paper copy or electronic media, such as a CD or a USB, and you can include the cost of postage. You may not include costs that are associated with the verification, documentation, searching for the PHI, maintaining systems. You can't recoup any costs for data access or storage, even if that might be authorized by state law. So it's very important that you can only include the costs of the labor, supplies, and postage. There are several different methods for calculating this cost. You can calculate the actual cost, which is the actual labor costs that were used to fulfill the request, the actual supply cost, and the actual postage cost. It might simplify things if you want to calculate an average cost. So instead of calculating the cost individually per request, you can develop a schedule of costs for labor based on average labor costs plus supply and postage. But if you do so, make sure that you document how you calculated the average cost. Or primarily in the electronic records area, you can also charge a flat fee for all requests for electronic copies of the PHI, provided the fee does not exceed $6.50. And that must include all labor, supplies, and postage, so no double dipping here. A little bit about per page fees. We hear sometimes about per page fees. There's a state statute that authorizes per page fees. However, for HIPAA right of access purposes, the standard rate can be calculated and charged as a per page fee only where the PHI is maintained in paper form and the individual requests a paper copy of the PHI or asks that the PHI be scanned into an electronic format. But the important thing here is that even if there is a per page fee, it must still actually be based on actual cost. And so I wanted to go through that refresher because I think that there's been a lot of confusion about the fees exception for information blocking. It's not the same as the fees issue with the right of access under HIPAA. It could be easily confused, but we don't want a situation where you replace one policy with the other. They're still separate, but that might be an applicable, that you would still obviously use a fees exception if you charged an appropriate fee for records and then were accused of information blocking. That's the end of the 8 exceptions. A little bit about how this might be enforced. There has been a proposed rule by the Office for Inspector General, which is the office that imposes civil monetary penalties. They do seem to be proposing a rule framework where you could be engaged in, you could receive civil monetary penalties for engaging in information blocking. This rule was proposed on April 24th of this year, and comments were taken and closed on June 23rd. We don't have a final rule here yet, but the important thing is so far, it seems as if the civil monetary penalties will only apply to health IT developers or other entities that are offering certified health IT, and so far would not apply to healthcare providers. However, it is very likely that we'll see continued enforcement rolling out as far as healthcare providers who engage in information blocking. So this is not an out of the woods. This is more likely something that's coming down the line. I'm going to turn it back over to Lynda to kind of summarize what you actually need to do before November 2nd.
Okay, thanks, Amy. Boy, I don't know about y'all, but I thought HIPAA was complicated, but this is in many ways worse than HIPAA was, and it overlaps with HIPAA. So I think we've got our work cut out for us, but we will certainly, I guess, get through it because we got through HIPAA. As far as the summary goes, the ONC final rule, we're going to need to have a policy on information blocking, and that's going to also involve us revising some of our HIPAA privacy policies. Our compliance date is November 2nd of this year. Whether we actually can meet that exact deadline, I think is kind of questionable. This whole issue of information blocking and the Cures Act, I think, was not on anybody's radar. It didn't get any press really at all. So I think that we will all be doing good to basically get all of these policies in place, first quarter of 2021. I would say it is very doubtful that we would see any enforcement, between November 2nd and, the end of the first quarter of next year. But at any rate, the CMS final rule allows CMS to put on the wall of shame, if you will, providers that are engaging in information blocking. As of the fall of 2020, that is literally what the rule says. There is no date. Also, the CMS final rule allows CMS to put on the wall of shame providers who fail to update their digital contact information in the NPPES in the fall of this year. And again, no date given. We've got to keep in mind that Medicare condition of participation requirement to send electronic notification of admission, discharge, and transfer event notifications of May of next year, because we are dependent on those software providers to be able to help for us to be able to comply with that requirement. So, by way of summary, the provider impact of the ONC rule and our compliance with that is required by November 2nd. We need to review and revise our HIPAA privacy and security policies and other policies that may be out there that are relevant to access and information sharing to make sure that they comply with the information blocking rules. Make sure that we include procedures for patient requests for EHI, which, by the way, EHI is equivalent to the designated record set. So don't think that we have some separate definition, even though we're using a different term. The definition of EHI is the same as the designated record set. We need to review our procedures regarding our fees for patient records. We need to be sure that we timely respond to requests for access to data. Check to make sure that we're covered under an exception if there's a reason that we can't provide access, if we are withholding access or if we're delaying access for some reason. And retain documentation to support the reason that we're withholding or delaying access, because we need to be prepared to defend ourselves. If we get accused of information blocking, document when we got the request for the information, and if we did in fact furnish the information, how long did it take us? If we didn't furnish the information, what exception applied to allow us to not furnish the information. As far as the CMS rule goes, review the attestation in the MIPS reporting Make sure that these statements reflect that you're not engaging in information blocking, because that's going to affect your Medicare reimbursement, in addition to being placed on the wall of shame. There's no exact deadline as to when it's going to affect your Medicare reimbursement, but it's going to eventually. Also, update your digital contact information in the NPPES system, because again, that'll get you on the wall of shame if you don't. And then prepare to make those admissions, transfer, and discharge notifications beginning in May of 2021. So that's a summary of what is required of providers in those two final rules. There are just a couple of things that we wanted to mention that are coming up on the horizon very soon, just to make sure they didn't fall off your radar. The first is the price transparency final rule. This is effective January 1, 2021. I know we've been talking about this for years. There have been multiple versions of this rule come out, but it's never had any teeth in it. It's never really been finalized, but this time it is. So there are two requirements. We've got to publish the 5 standard charges for all items and services that are delivered to patients in a comprehensive machine readable digital file. And these 5 standard charges are gross charges, payer-specific negotiated charges, discounted cash charges, de-identified minimum negotiated charges, and de-identified maximum negotiated charges. And then we've also got to publish a list of standard charges for at least 300 non-urgent, what are called shoppable services in a patient-friendly format. And again, that is effective January 1, 2021. Another, I would say, hot topic item is HHS recently issued new guidance for the CARES, and we are talking about CARES Act here, CARES Act reporting. This was just issued on September 19th, and it applies to recipients of CARES Act provider relief funds, that you're required to submit reports that are composed of healthcare related expenses that are attributable to COVID-19 that another source did not reimburse and will not reimburse. And this report should include general and administrative expenses as well as other operating expenses. And the report should also include provider relief payments that were not fully spent on healthcare related expenses that were attributable to COVID, using year-over-year comparisons to determine lost revenue, and that is capped at the net gain from healthcare related activities in calendar year 2019. In other words, you can't make more money in 2020 than you did in 2019, and that's a big change. There's also a 6-month rollover into 2021. So you have an additional 6 months to use those remaining funds into 2021. And the reporting guideline is the time period from February of 2021 to July of 2021. So we just wanted to mention those couple of things that are on the horizon. I know that we have thrown a whole lot of information out there to you this morning. But we have enjoyed talking with you, and now we'll take any, or try to take any questions that you have.
Lynda, we do have a couple of questions in the chat box. One is, outside of the risk of harm or other exception, is there any wiggle room to hold test results for a small time frame, a day or so, before release to patients? The delay would allow the provider time to review the results.
Yeah, I think it's the patient harm I think that would be the exception that we would rely on there.
Okay. And then the other question is also, do you feel that the progress notes in the US CDI version 1 includes progress notes written by disciplines such as case management, dietary, social work, etc.? There's some confusion and some folks believe it is provider progress notes only.
No, I think it includes the whole care team, not just providers.
Okay. And if anybody else has additional questions, if you want to put those in the chat box, there may have been some that they sent directly to Amie, if you want to look in your guys' chat box.
Okay, we'll check that.
We don't have any direct questions unless I don't know how to use the chat box. I only see the messages from you, Lindsay.
Okay. Okay, well, it looks like people are pretty quiet. On the evaluation that we sent via SurveyMonkey, and I'll follow up again with an email after this, if you have questions that you didn't want to put in the chat, you can put them on your evaluation, and I will send those to Lynda and Amie for them to answer, and we'll get all the answers back to everyone who is registered for today. So I don't have anything else unless there's something else that you would like to cover, Lynda or Amie.
I think that's all we have. That was a lot of information to throw at everyone. So we'll be happy to field follow-up questions if anyone has them.
Okay, well, great. I want to thank Lynda and Amie again for being with us today. Don't forget to complete your sign-in sheet and send that back to us, as well as your eval. If you have any questions, again, put those on your evaluation, or you can send me an email, or Lynda or Amie an email. And again, I will follow up after this webinar. I just saw a question pop up. Yes, I will follow up this webinar with additional information, as well as the recording of this webinar and the PowerPoint from this event. So I appreciate everyone who was willing to join us today. That was a lot of information. It's very overwhelming, so it's good that we recorded it. So, and with that, I pray that everyone has a safe and healthy week and rest of the year. Hopefully 2021 will get here soon, and there will be a change, of course, with this pandemic. So thank you so much and have a great day.